Welcome back. We'll continue our discussion on pain management in the laboring woman. This information is from chapter 16 in your Flag and Pillow Terry textbook. In section 1, we addressed the non-pharmacological ways that we manage pain with the client in labor. We talked about managing pain also in the post-operative C-section client, and then we talked about some of the meds that you might be working with in the labor setting when a woman is experiencing pain and some of the considerations. Your next slide brings you to blocks, quote unquote, because you'll hear sometimes people say, oh, well, these are all blocks, and this is where the pain is blocked. So you've already heard me mention in this lecture the term intrathecal. That's spinal. So that's whenever we inject medication into the spinal route to block pain or anesthetize pain, that's an intrathecal. And I spoke a bit about Duromorph, which is a newer, effective way to manage postoperative C-sections in particular. Then we talk about your local block, quote unquote, which is typically the blocks that are used or the anesthetics that are used to manage pain locally on a vaginal delivery within the perineum. So, and that's typically delivered 10 to 20 minutes before delivery, and it's an injection, and it has usually a short half-life, like something similar to a lidocaine. You could compare it even to the blocks that are used when you have some dental work. And then finally, the other it's pretty classic is your epidural. The epidural is placed into the epidural space of the spine, and that usually the access by the anesthesiologist is somewhere between the fourth and fifth lumbar space. Your role as nursing is to first and foremost provide comfort for the patient while she has this procedure done. A big piece of this is assisting with positioning, and the two choices for position, according to the literature, would be to either have the patient be sitting upright at the side of a bed, where the patient would lean forward and drape her arms over, if you read the literature, it'll speak to the bedside table, or perhaps even reach up and around over your shoulders as the nurse. The goal here is to open up the spinal processes so that the anesthesiologist working from the other side of the bed or stretcher is able to access and palpate and perform a thorough assessment for proper placement. And the second position would be that the patient is side lying if she wasn't able to get to a sitting upright position. The other important role in managing epidurals on the part of the nurse is really prior and post. Almost every agency who's working with epidurals for the laboring client will have a policy or physician orders that would require you, the nurse, to infuse a bolus IV of either lactated ringers or normal saline, typically, to prevent the rapid effect of hypotension because of the epidural placement after the epidural has begun. So you will see that in the literature, it's between 500 and 1,000 mLs minimum. That's a minimum. Some agencies have even higher, but a minimum of 500 to 1,000 mLs of a bolus infusion, typically given over 30 minutes prior to the placement of the epidural catheter and medications. And again, this is an intervention that's typical, it's routine, it's practiced, and it's to prevent the hypotensive effects of the epidural meds. Given that we are aware now of that side effect, post-procedure, the most important intervention would be to assess the blood pressure as frequently as every 5 minutes for the first 30 minutes. And we're going to have the mom rest on her side while we manage and assess her reaction and her baby's reaction to the epidural placement. When we talk about fetal well-being, and this goes back to normal newborn care and normal labor care, whenever a procedure is done on a laboring mom, we always check fetal heart rate before the procedure and after the procedure. So while that infusion is going in right before the epidural is placed, we should do a fetal heart check at that moment. And then once the epidural has been placed, we would be checking those blood pressures on mom, but also checking the fetal heart rate to make sure that the fetus has